In general practice, most patients come in with reasonable needs and respect for the process. Doctors listen, offer evidence-based care, and clinics do their best to accommodate every patient fairly. But a small group of patients can have an outsized impact on a clinic, not because of serious illness, but because of how they engage with staff and doctors. They often make unreasonable or inappropriate demands, take up a great deal of time, and create an emotional and financial burden that the current Medicare system doesn't recognize or support. These patients might request medications like diazepam or other restricted drugs, even when it's not clinically indicated. Others repeatedly ask for medical certificates or reports that doctors cannot ethically provide. Some become aggressive or manipulative when told no. They may call the clinic over and over, send long emails, or demand urgent action on issues that don't require it. And most of these interactions happen outside of billable consults. In other words, the doctor or receptionist spends real time and effort, but the clinic receives no Medicare reimbursement. This is why some staff privately call them expensive patients. Not because they are being charged more, they aren't. But because they take up more time, more stress, and more unbillable hours than most others combined. It's important to recognize the ethical complexity here. These patients are still people. Some are dealing with addiction. Others might be in distress. Some may not even realize the impact they are having. So we can't simply label them and push them away. But general practices aren't just health providers, they are small businesses too. And when staff are overwhelmed or burnt out by these interactions, the quality of care for everyone can suffer. Clinics cannot just stop seeing a patient because they are difficult. There has to be a clear reason. For example, repeated abuse of staff, or a breakdown in the doctor-patient relationship that makes continued care unsafe or unproductive. In those cases, clinics must document the concerns carefully, notify the patient respectfully, and ensure that ongoing medical needs are not left unaddressed. But the decision to end care is not taken lightly, and it comes with legal and ethical responsibility. So what's the alternative? Some have suggested introducing a social contract, a short, clear statement of what patients can expect from the clinic and what the clinic expects in return. Things like prescriptions are issued only during consults, inappropriate demands won't be fulfilled, repeated abusive behavior may result in the clinic no longer being able to offer care. This kind of document could help set expectations early, but it also runs the risk of sounding cold or transactional, especially to new or vulnerable patients. There's no perfect solution. Each clinic has to weigh compassion with sustainability, fairness with boundaries. But one thing is clear. The system needs to recognize the hidden cost of unbillable work. And practices need better tools and more support to handle these challenges without sacrificing care or burning out their teams. This isn't about blame. It's about balance. And it's time we talked openly about it. To read the full article, visit generalpracticertraining.com.au.